The likely reason for relapse is failure to eradicate the spirochete completely with a 2-week course of intravenous ceftriaxone, wrote Drs. Legigian, Kaplan, and Steer in their seminal 1990 paper covering chronic neurologic Lyme disease. This observation remains as relevant today as it was over 3 decades ago, highlighting a persistent challenge in the treatment of Lyme disease: the difficulty in fully eliminating the Borrelia Burgdorferi bacterium, which can lead to relapse or persistent symptoms even after what is considered adequate treatment. In chronic Lyme disease, or what is often referred to as post-treatment Lyme disease syndrome, PTLDS, patients continue to suffer from symptoms such as fatigue, pain, and cognitive difficulties long after completing the standard antibiotic courses. This condition has sparked considerable debate within the medical community. Some experts believe that ongoing symptoms are due to lingering effects of the initial infection, while others propose that they may be due to an active, persistent infection that was not fully eradicated by the initial treatment. The 1990 study by Legigian, Kaplan, and Steer explored these possibilities by examining patients who had been treated with a 2-week course of intravenous ceftriaxone. Despite this treatment, some patients either relapsed or failed to recover fully, leading the authors to speculate that the spirochete might not have been completely eradicated. This concept has been supported by subsequent studies suggesting that Borrelia burgdorferi can persist in the body in a dormant state, possibly shielded within tissues where antibiotics have limited penetration. More recent research has further explored the idea of persistent infection. Studies have shown that Borrelia burgdorferi can form biofilms, that is, complex communities of bacteria that are more resistant to antibiotics. These biofilms could potentially harbor bacteria that reemerge after the initial course of antibiotics is completed, leading to the recurrence of symptoms. Moreover, the nature of Lyme disease itself complicates treatment. The bacterium Borrelia burgdorferi can exist in multiple forms: spirochete, round bodies, and biofilms, which might require different antibiotics or treatment approaches to fully eradicate. This complexity may explain why some patients do not respond to the standard treatment regimen. For patients like mine, who experience a relapse after standard treatment, the journey can be frustrating and disheartening. The initial hope of recovery is replaced by confusion and concern when symptoms return or persist. This situation emphasizes the need for ongoing research into more effective treatment strategies for chronic Lyme disease, including longer antibiotic courses, combination therapies, and alternative treatments that address the different forms that bacterium can take. The challenge of treating chronic Lyme disease also raises important questions about the broader healthcare system and its approach to this condition. There's a pressing need for more awareness among healthcare providers, more research funding to explore the underlying mechanisms of persistent infection, and better support systems for patient managing the complexities of this illness. In conclusion, the issues of relapse in Lyme disease treatment is not just a clinical problem, but also a deeply personal one for patients who struggle to regain their health. It highlights the importance of individualized treatment approaches, ongoing patient support, and a continuous pursuit of knowledge to develop more effective treatments for this complex and often misunderstood disease.